Thank you, sir. Next presentation will be by Dr. Shubhada Kanhere. She is head of pathology department at HCG Cancer Center, Ahmedabad. She has over 30 years experience in the field.
Hi, good morning everybody. I thank the organizers to give me an opportunity to speak in front of such an august audience. And this is the pointer, is it? Yeah. Today I am going to speak on non-squamous cell tumors of larynx, which are rare but well described pathologies. Laryngeal carcinomas overall have an incidence of 3.8% in males and 0.5% in females. In India, it accounts for 30,000 new cases of laryngeal cancer and ranks at number 11. Squamous cell carcinoma obviously is the most commonest of all those neoplasms. A range of other neoplasms have also been described in the larynx over the last several decades, and WHO 2022 Blue Book has been updated to include these. Why is it important to know about these pathologies? Because majority of the available evidence regarding optimal treatment is based on studies of squamous cell carcinomas. Yeah, thanks. Okay. Right. And the management of non-squamous cell tumors, it relies mainly on extrapolation of data from squamous cell carcinomas or similar histologies in non-laryngeal subsites or small case series. However, we must know that these specific histologic type of tumors have different biologic behavior, and they are associated with different prognosis and survival rates, and each tumor type has variable response to different treatment modalities. This is a WHO classification of laryngeal tumors. Most of them are squamous cell carcinomas, and specific to larynx are cartilaginous tumors. However, a whole range of other tumors occur in larynx. Let us go step by step. Commonest are the neuroendocrine neoplasms. In neuroendocrine neoplasms, we have neuroendocrine tumors, neuroendocrine carcinomas, and head and neck paragangliomas. For neuroendocrine tumors, well-differentiated neuroendocrine tumors are the second most common type of tumors in larynx after the squamous cell carcinomas. And grade 2 is commoner than neuroendocrine carcinoma than grade 1. It is more frequent in males, and sometimes it can also be associated with raised serum calcitonin levels. Then it's a challenging scene. How do you differentiate a well-differentiated neuroendocrine tumor from medullary carcinoma and paraganglioma? Paraganglioma, it's easy. You do a cytokeratin, you can discern. To discern from medullary carcinoma from thyroid, PAX8 and TTF1 positivity, and imaging and molecular workup. Molecular workup for RET and RAS will help. This is how the well-differentiated neuroendocrine tumor looks like. That is the histology. There are 2 grades in the larynx for well-differentiated neuroendocrine tumor, and we discern them basis on mitosis and necrosis. Ki67 doesn't play a role in grading, but it is important to discern from neuroendocrine carcinomas. In the Western world, they also do RB1 and P53. P53 we do in India, but RB1 at present we are not doing. Prognosis and prediction of well-differentiated neuroendocrine tumors, I will just run quickly through this, that they have overall good prognosis. When they spread to lymph nodes, surgical resection and chemoradiation is done. Small cell neuroendocrine carcinomas, which are poorly differentiated high-grade neuroendocrine carcinomas, as you can see in the histology slide, they are very pleomorphic. The nuclei mold on each other, high nuclear cytoplasmic ratio, and the other photograph is of immunohistochemistry of INSM1, that is the new kid on the block for neuroendocrine tumors, supposed to be very sensitive and specific marker. And Ki67 for these tumors is often very high. It is at least greater than 70%. 60% of head and neck small cell carcinomas, they arise in larynx, and majority of them are in the supraglottis. And small cell neuroendocrine carcinomas comprise 50% of laryngeal neuroendocrine tumors. What is important for these tumors is their differential. Sometimes basaloid squamous cell carcinomas and solid variant of adenoid cystic carcinomas can be confused with these neuroendocrine carcinomas. So the way to discern is the absence of neuroendocrine markers. Like I showed you this INSM1, brown color, that will be absent in a squamous cell carcinoma and adenoid cystic carcinoma. And secondly, adenoid cystic carcinoma will be positive for myoepithelial markers, which is absent in a neuroendocrine carcinoma. Squamous cell carcinoma obviously expresses P63 and P40. Large cell neuroendocrine carcinoma and small cell neuroendocrine carcinoma is just a matter of academic interest because their treatment essentially is same, and large cell is called large cell because the cells are large and they have prominent nucleoli. Otherwise, it is very much similar to a small cell neuroendocrine carcinoma immunohistochemically and treatment-wise. Combined neuroendocrine carcinoma, one must remember, combined neuroendocrine carcinoma is a carcinoma in which there is a mixture of usually squamous cell carcinoma and a neuroendocrine carcinoma. So the typical morphology of a squamous cell carcinoma is not there, and if we see molding of the cells, we need to order an IHC. About 5% of the small cell neuroendocrine carcinomas can occur with squamous cell carcinomas. Moving on to the next category, tumors of minor salivary gland, pleomorphic adenoma, which I suppose everybody knows quite by heart in head and neck area. It's PLAG1 and HMGA2 are the sensitive and specific markers and new kids on the block. Mucoepidermoid, adenoid cystic, hyalinizing clear cell and adenocarcinoma can occur in larynx. Talking about adenoid cystic carcinoma, because adenoid cystic carcinoma and mucoepidermoid carcinomas are commoner in larynx. Adenoid cystic carcinoma, as you can see in the photomicrograph, histology demonstrates cribriform architecture. Perineural invasion is a desirable criteria, and the markers, as I already expressed, are calponins. I use smooth muscle myosin heavy chain frequently because it's a very specific and sensitive marker. And P40 obviously. Majority of them occur in subglottis, and laryngectomy when it is involving subglottis, total laryngectomy and partial for supraglottic tumors followed by radiotherapy is a treatment. They demonstrate MYB, MYB-L1 and NIF-B rearrangement. So in difficult cases, one can go for that. Mucoepidermoid carcinoma of the larynx, one should be aware that it can happen because adenosquamous necrotizing xylometaplasia are the differentials, and in these three you get squamous pearls. Though mucoepidermoid has epidermoid name in that, it doesn't exhibit squamous pearls. Nowadays, MSK-CC2 two-tier grading system is in vogue, as they discussed in CAP, and it's very simple. It divides the mucoepidermoid carcinomas even in the salivary gland into low grade and high grade. At present, WHO doesn't endorse any specific category, but this is the new development, and it depends on the number of mitosis and presence of necrosis. Very simple, easy to apply. And adverse factors, just like salivary gland, are high grade, positive margin. Fusion negative carcinomas have worse prognosis. Now we will go to next category. In the mesenchymal tumors, which are unique to larynx, as Diva was showing a case of chondrosarcomas. In general, cartilaginous tumors account for 0.2 to 0.5%, and chondrosarcomas are more common than chondromas. The WHO criteria for chondroma is it should be less than 2 centimeter, it should be circumscribed without any destructive growth. Whereas chondrosarcoma, if you see here in the radiology and in the down image also, gross image, it infiltrates, it has that popcorn type of calcification, and see in the histology how it is infiltrating. The microphotograph exhibits the extensive pleomorphism, which is shown in the lowermost right-hand corner. And above that, you see how the lobules or cartilages are invading. That is how a chondrosarcoma is distinguished from a chondroma. So even WHO says that the desirable criteria for diagnosis of a laryngeal chondrosarcoma is imaging finding of an expansile destructive intracartilaginous mass. Because what happens is, if you give a small needle biopsy, sometimes a low-grade chondrosarcoma, it is difficult to discern from a chondroma. And that is where the imaging is important. One has to see that ring-like or popcorn type of calcification. That is a desirable criteria. The subtypes of chondrosarcoma are rare in the larynx. Differential diagnosis of chondrosarcoma is important. Chondrometaplasia usually manifests as multiple nodules involving vocal cord which blend into the adjacent stroma. Second important differential of a chondrosarcoma is whether it is heterologous in a spindle cell squamous cell carcinoma. Usually in chondrosarcomas we don't see a spindle cell element. So if one sees a spindle cell element along with atypical cartilage, one has to think of a spindle cell squamous cell carcinoma. And take home message is that on a needle biopsy it can be difficult to discern a chondrosarcoma from a chondroma. Size, destructive potential and calcification are important. Going on to the soft tissue tumors. This is the list of soft tissue tumors usually which can happen anywhere. I will go to the soft tissue tumors which are common in the larynx. Out of them, desmoid fibromatosis. Desmoid fibromatosis is a fibroblastic tumor which has very bland cytology. And usually we call a desmoid fibromatosis a fibromatosis when it expresses nuclear beta-catenin. However, in 20% of the cases, it can be negative. The cause is unpredictable, and important thing is that the recurrence after surgery does not really correlate with the margin status. In larynx, they say one can wait and see policy. The cause is unpredictable and anti-hormonal NSAID or TKI can be tried. Next category is solitary fibrous tumor. This is a histophotograph of the solitary fibrous tumor. If you see those spindle cells which are arranged in a patternless pattern category, that is the characteristic description. The radiology image is of solitary fibrous tumor and the immunophotograph is STAT6. STAT6 is a very specific marker for solitary fibrous tumor, and that happens because there is a NAB2 STAT6 rearrangement in solitary fibrous tumor. Recurrences are associated with positive margin, and in solitary fibrous tumor we don't have a benign or malignant category. They are considered with low grade, like all the tumors have a malignant potential, and there are multiple risk models which use age, size, cellularity, mitosis, necrosis and pleomorphism. So moving on to the next tumor is a low-grade myofibroblastic sarcoma. This is very similar to fibromatosis. However, we discern when there is moderate nuclear atypia. Nuclear atypia is not accepted for fibromatosis. And in the figure, as you can see in the lower corner, that is called a checkerboard pattern of infiltration. The tumor infiltrates the skeletal muscle in a checkerboard fashion. Immunohistochemically, it is positive for calponin, but these markers are non-specific. These markers are fibroblastic markers. So fibroblastic markers, moderate grade cytologic atypia, one should think of a low grade myofibroblastic sarcoma. Local recurrences are common and metastasis can also occur. Next is a very interesting tumor, inflammatory myofibroblastic tumor. This is actually a very bland tumor, but it metastasizes. And as you can see in the photograph there, it is composed of fibroblasts, quite a lot of inflammatory cells, lymphocytes, plasma cells, and eosinophils. And 50 to 20% of them develop in the neck. Most commonly, they develop in the larynx, maxillary sinus, usually affect adults. And they can have various histologic patterns, as I am showing you here, hypercellular areas, hypocellular areas, or granulation tissue-like areas. They express ALK and ROS1. The differentials for them are spindle cell squamous cell carcinoma, vocal cord polyp, and IgG4 related disease. Distant metastasis can be associated with ALK negativity on IHC, and ALK inhibitors can improve their outcome. Next is a very rare tumor. Nevertheless, it happens in larynx in immunocompromised patients, and that is EBV-associated smooth muscle tumor. These tumors can have cellular atypia, mitosis, like you see, that is an example. That's a submucosal tumor, and one can see significant cellular atypia and even a mitosis. However, there is no necrosis, and they exhibit very indolent behavior. How do you diagnose them? EBER-ish. That is Epstein-Barr virus RNA, which is demonstrated by in situ hybridization. And the prognosis depends on the control of immune condition. Rhabdomyomas and rhabdomyosarcomas are skeletal muscle tumors. These are adult type of rhabdomyomas, and the other ones, which are very blue, they are fetal type of rhabdomyomas. Both of them are benign tumors. Fetal type of rhabdomyomas should not be confused with rhabdomyosarcomas. Fetal type of rhabdomyosarcomas are usually very circumscribed and superficial in location. Adult type of rhabdomyomas, as I showed you, they are polygonal and a very distinct, they have very distinct type of histology. Rhabdomyosarcomas, when they occur in larynx, they are just like when they occur in soft tissue. And one should remember that the fusion determines their prognosis, because in needle biopsy it might be difficult to predict which type of histology it is, and fusion positive have worse prognosis. So it makes sense to do molecular tests when one encounters a rhabdomyosarcoma, because the prognosis and treatment depends on fusion positive versus fusion negative type of rhabdomyosarcomas. That is a photomicrograph of rhabdomyosarcoma, the image, and the positivity for myogenin. Immunohistochemistry actually is a play of brown versus no brown. Ewing sarcoma I have discussed here because in head and neck one gets a very interesting variant of Ewing sarcoma, which is called adamantinoma like Ewing sarcoma, and they have not yet settled on, I will just take one more minute. Adamantinoma like Ewing sarcoma is important because it shows exact molecular rearrangement. It is a malignant round cell tumor, but it has evidence of squamous differentiation. It can occur in head and neck. They have not yet settled to call this adamantinoma like Ewing sarcoma or a carcinoma with Ewing sarcoma like features. There are disputes going on. Justin Bishop and Lisa Rupert has written an excellent article regarding this tumor. One should be aware that if you have a malignant small round cell tumor, look for squamous pearls in head and neck before signing it off as Ewing sarcoma. And the last tumor is a solitary plasmacytoma, which happens in head and neck very frequently because 80% of solitary extramedullary plasmacytomas occur in head and neck, and they are localized usually. One has to obviously rule out the presence of multiple myeloma or plasmacytoma. That is an example of solitary plasmacytoma, and they have to be monoclonal. So they can be confused if they are immature with carcinomas, melanomas, lymphomas, and extramedullary myeloid sarcomas. Prognosis and prediction, they usually have indolent course. 10% can progress to plasma cell myeloma. These are my references, and thank you very much for your attention.